One can afford to miss a PhD, a primary headache disorder, but never an OST, an ominous headache disorder. Recently, we had a case in Kerala where brain tumor was presented with a squint and diagnosis was delayed for about 6 months. Brain tumor headache, very frightening, 67% present like a mild moderate headache. That is something like a tension type headache. 50% of all brain tumors in children are subtentorial, and cough headache is symptomatic until proved otherwise. So every child with cough headache must be imaged. Sudden onset, acute onset is always a red flag, and sudden onset can be thunderclap. That means maximum intensity in 1 minute. That is the most ominous headache that you can encounter.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like video so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Good evening, everyone, and welcome to this night symposium. I thank Medflix and Dr. Sanika for this initiative today. You know, headaches are very common. Recurrent headaches are also very common. According to different studies from different parts of the world, more than 85% of these headache patients go to primary care. And we have no idea about how many go to OTC, over the counter medications, and complementary care practitioners. Fortunately, most headaches are primary and benign. Benign primary or benign secondary. Not all secondaries are ominous. So dangerous headaches are rare. As they are rare, they can be missed in a busy practice. And in this medico-legal era, the common dictum is one can afford to miss a PhD, a primary headache disorder, but never an OST, an ominous headache disorder. Recently, we had a case in Kerala where brain tumor was presented with a squint and diagnosis was delayed for about 6 months. Now, you know the headache document, the Encyclopedia of Headache Classification, ICSD-3, International Classification of Headache Disorders, Edition 3. This document has 4 parts. First part is the primary headaches. There are 4 groups in that. Second part is secondary headache, 8 groups there. And the third part is neuralgias and neuropathies, known as painful lesions of the cranial nerves and other facial pain. And then there is the appendix, the orphan criterias, the entities where we need more evidence and more research. And we also know that there are some entities not in ICSD-3, out of the box entities. Classical example is Alice in the Wonderland syndrome. But these primary groups can be ominous. You look at group 4, other primary headaches. They are sitting on the fence. They can jump onto the ominous group any day, like cough headache, thunderclap headache, new daily persistent headache, hypnic headache, and sex and exercise precipitating headache. So these can be very dangerous headaches. And you see cough headache, is it primary or ominous? It can last 1 second to 120 minutes. And you know the most important cause is Arnold-Chiari malformation. Up to 40% cough headaches can harbor a Chiari malformation. And the other ominous lesions with cough headache are CSF hypotension, vertebrobasilar disease, posterior fossa, middle fossa tumors, midbrain cyst, subdural hematoma, aneurysms, and RCVS, reversible cerebral vasoconstriction syndrome. And as we know, 50% of all brain tumors in children are subtentorial, and cough headache is symptomatic until proved otherwise. So every child with cough headache must be imaged. Now, secondaries are not always ominous. They can be benign. Many secondaries can be benign, like refractive error headache, cervicogenic headache, sinus inflammatory headache, depression, post-traumatic headaches, most of them, trochlear headache, substance use, diet and drugs, high altitude, and hypothyroidism. They are not killer headaches. They can be treated without any problem. And if you go through ICH3 secondary groups, they are so scary. Many ominous headaches can present as a primary headache, like migraine or tension, like cerebral venous thrombosis, pseudotumor cerebri or IIH, carotid dissection, AV malformation, cavernous angioma, Sturge-Weber syndrome, and very rare genetic vasculopathies, Cadastil and Melas, Handel syndrome, cerebral amyloid angiopathy, and Moya-Moya angiopathy. And you look at brain tumor headaches, pituitary adenoma can present with any type of primary headache. And primary CNS angiitis, headache has no specific features, any type of headache. And brain tumor headache, very frightening, 67% present like a mild moderate headache. That is something like a tension type headache. So when do we suspect a sinister brain lesion? So we have these so-called red flags, symptoms and signs which will alert us to the possibility of a sinister brain lesion. And we have mnemonics to remember these red flags. And the most popular is SNOOP. And there are SNOOP modifications. Different experts have expanded SNOOP from SNOOP 4 to SNOOP 10. And S is systemic symptoms. Fever, weight loss, anorexia, myalgia, chills, any endocrine symptom, any CNS symptom, any psychiatric symptom. But there is one point that we have to keep in mind. Headache and systemic symptoms must come together. Very close temporal relation. Then only you can correlate systemic symptom to headache. And second is secondary risk factors, that is cancer and HIV. And N is any neurological symptom or sign except benign symptoms and signs like pseudopapilledema, migraine auras like visual aura, sensory aura, speech aura, which can confuse you, and congenital and physiological nystagmus, physiological anisocoria, and something known as Duane's retraction syndrome, where there is lateral rectus paresis. So you can suspect that as a false localizing sign of a raised CSF pressure. So better to refer to an ophthalmologist or a neurologist when you have a confusion about these benign symptoms and signs. And O, onset and old age. Sudden onset, acute onset is always a red flag. And sudden onset can be thunderclap. That means maximum intensity in 1 minute. That is the most ominous headache that you can encounter. The origin can be ruptured aneurysm to meningitis. There are many causes. And second O is old age. Anybody above 50 or 60, new onset headache or different from past headache. You think of giant cell arteritis, chronic subdural hematoma, and subacute or acute angle closure glaucomas. And P are P symptoms and signs. 4, 6, 10 P symptoms and signs are there now. I have documented 28 P symptoms. I will discuss that briefly later. And the main P symptoms are papilledema. You know how important papilledema is. Positional headache or postural headache. When they lie down, there is no headache. When they get up, there is headache. Precipitation by Valsalva-like maneuver, like cough headache. And progressive headache or change in pattern of an existing headache. Once a month becoming once a week. And I have this mnemonic. This is from my 35 years of documentation. I warn you, please. I am not an ordinary headache, benign headache that you come across every day. I am somebody ominous. Be very careful about me. I is incapacitating headache. W is worst headache of one's life. A is abrupt onset headache. R is recent onset headache. N is nocturnal headaches, any neurological symptoms or signs, neck stiffness, or nuchal, posterior headaches. U is unusual headache or unusual symptoms. And P symptoms like P in Snoop, I have 25 P symptoms and signs. If you get only one symptom, either P symptom or other symptom, the possibility of getting a positive scan is only 1 in 10. 90% will be normal imaging. But if you get a sign and a symptom, it can go up to 60%. Imaging will be positive. This is incapacitating headache. You know what they tell us? They tell you that I am not able to do my daily routine, my daily activities. And these two patients told me the same symptom, and they had papilledema, symptoms of papilledema, and symptoms of brain tumor headache features. Now, symptoms of papilledema. You may not have an ophthalmoscope. You may not be trained in ophthalmoscopy. And sometimes it's very difficult to look at the disc, especially when there is meiosis, when there is cataract, when there is corneal opacity, or a patient is not cooperative. So you don't have to worry. You remember these 4 symptoms of papilledema: transient blurring of vision, transient diplopia, pulsatile tinnitus, and photopsia or flashes. So if you get one of these symptoms, you have to suspect papilledema and investigate. This is the true papilledema, and on the right is a pseudopapilledema. So pseudopapilledema can confuse you, and clinically one can differentiate between both. Rarely only you have to go in for an ultrasound scan or a CT scan. So whenever there is a confusion, get an ophthalmology opinion. And classical brain tumor headache features. This is given in ICSD-3, progressive headache. Any progressive headache that is, suggestive of a brain tumor. And worse in the morning. When they wake up, they will have the worst of the headache if you look at the entire day. And then precipitation by Valsalva and associated with vomiting. My 2 patients had all these classical symptoms. This is incapacitating headache. My first incapacitating headache way back in 1989. This youngster was rolling on the bed when I went to examine this patient. Rhinoconjunctivitis, sinusitis, and then the brain abscess. And then W, that is worst in life. I do get headache, but this is the worst. I never had a headache like this. This is, a posterior cerebral artery infarct, occipital infarct. This is a glioblastoma. These are brain bleeds. All complained of worst headache in life. Then A is abrupt onset. Whether it is thunderclap or not, abrupt onset is the key. It may be moderate, it may be mild. Doesn't matter. When you get a complaint, abrupt onset, the most urgent rule out is a subarachnoid hemorrhage, and most revered investigation is a plain CT. We think, MRI is always superior. That is very true. But whenever you suspect subarachnoid hemorrhage, aneurysm rupture, go for a plain CT scan. If you can get it done within 6 hours, 99% you can see the blood. That is confirmatory. If it is 1 day delayed, the positivity becomes 93%. And initial misdiagnosis all over the world, even in the West, 50%. And the commonest misdiagnosis, migraine. And missing these subarachnoid hemorrhage, mortality is 40 to 50%. And again, abrupt onset headache, you can see this subarachnoid hemorrhage, all presented with thunderclap headache. And again, thunderclap. This is on 4th day. You can see blood is disappearing slowly, but you can still see blood particles there. And this was, multiple aneurysms. This is CT angiography, which you can do in my place, Cherthala. And this is another worst headache known as sentinel headache. Sentinel means guarding against death. Before aneurysm rupture, 50% of patients get a very severe headache within a month of the rupture. And this is a middle cerebral artery aneurysm picked up on CT scan. And there is something known as exploding head syndrome. That is not thunderclap headache. That is a sound, a thunder, explosion, gunshot, or crash. They can also get photopsia, muscle jerks, palpitation, dyspnea, sweating, anxiety. They are very much frightened. It is a fraction of a second and they get up. It is secondary to damage or issues in the inner ear, rapid seizure in the temporal lobe, or an aura before migraine. So no need of any imaging when you get a patient with this very frightening sound in the skull, in the brain. And this is the recent headache, 1 week, 2 week duration. It is also known as, this is my own headache, like a cabaret dancer slowly exposing herself. These patients present with headache, but the diagnostic signs will appear over a period of days or weeks. And the commonest is herpes zoster ophthalmicus. They present with new onset headache, unusual headache, and the vesicle eruption may take up to 7 days. Optic neuritis, they present with vague periorbital headache, but the diagnostic symptom of blurring of vision can take up to 28 days. Then Tolosa-Hahn syndrome can take up to 15 days. They present with 15 days of headache. You have no clue what is going on, and by about 14th or 15th day, they get drooping and diplopia. And carotid dissection, 4 days of severe headache, more in the face and neck, and then they get Horner syndrome, mild ptosis and meiosis. And diabetic cranial neuropathy, where they get sixth nerve or third nerve palsy within a week. Initially, only headache. And ophthalmoplegic migraine, 4 days of severe headache, migraine headache, debilitating headache. Then they get ophthalmoplegia. Now it is known as RPOD, recurrent painful ophthalmoplegic neuropathy. And giant cell arteritis also can present with headache initially, elderly patients, and infarct, like a PCA infarct. First posterior pain, and then next day they can complain of blurring of vision. And there is another entity known as Vogt-Koyanagi-Harada syndrome, where they get severe headache like meningitis, but no fever. And by about 5th day, they get blurring of vision, secondary to uveitis. And N is like N in Snoop, neurological signs or symptoms, neuro-ophthalmological signs or symptoms, nuchal, posterior, nocturnal headache, and new onset headache. So remember N. All these can be ominous. But when you look at these nocturnal headaches, there are many benign headaches. Migraine headache, tension type headache, cluster, hypnic headache, hypoglycemia headache, hypertension headache, sleep apnea headache, and medication overuse headache. They all can present nocturnally. That is why when you go for imaging, you get 90% negative imaging. And these are the unusuals. Very vague headache. They tell you I get headache, but this is something very unusual. And this lady presented with severe supraorbital headache. There was nothing in the eye, and you open the curtain. That means you pull the lid up, you can see the origin of headache. This is scleritis, more of posterior scleritis. And this patient, meningioma, presented with very unusual sensation in the periorbital, supraorbital region. And this subarachnoid hemorrhage also, sudden onset of vague headache. So whenever you get a new headache, which is very vague, not fitting into any of the non-entities, be very careful and plan imaging or other investigations. Now comes the P symptoms. Symptoms and signs starting with P, and the most important for me is pituitary symptoms. When I look at, pituitary tumors missed everywhere, one must know the pituitary symptoms when they present with headache. They can present with any kind of primary headache, and you have to ask them whether any symptoms down the head. They may not correlate, symptoms down the neck to headache, like galactorrhea, amenorrhea, gynecomastia, infertility, skin changes, acanthosis nigricans, emotional disturbances, temperature dysregulation, altered thirst or altered appetite. So always ask any other symptom other than headache. So sometimes you get a clue that this could be a pituitary problem. And other P's are putting on weight related to pituitary and peripheral visual field. Always do confrontation visual field testing in every headache patient. You may pick up one or two in a year. Pituitary lesion, pituitary adenoma. All these are pituitary tumors presented with systemic symptoms, which I explained already. And also visual symptoms in pituitary, a change in visual behavior, temporal blurring, noon blurring, scotoma, diplopia, not improving with spectacles, loss of vision, vague blurring. They cannot explain what kind of blurring it is, overlapping of letters, and squinting. So, any of these unusual symptoms, always keep in mind a pituitary lesion. And sometimes a family album tomography. You go through the photographs. This is the marriage photograph, 28-year-old. This is 15 years later, pituitary adenoma. And this is acanthosis nigricans of pituitary adenoma. She also presented with migraine-like headache. And pyrexia. Headache is very common with pyrexia. So when to suspect a danger uh, sign or symptom. One is neck stiffness. Second is photophobia, severe photophobia. Third is severe headache or a different pain from previous headaches that they get whenever they get fever. Nausea, vomiting, and retrobulbar pain, and any CNS symptoms. In ICH3, there are 15 CNS symptoms given. So any CNS symptom with fever is very ominous. And this is a very recent case, fever of 3 weeks duration, was on treatment, and then she had severe headache with no past history of headache. Severe photophobia, admitted, fever subsided with injections, about to be discharged, and she got up with disorientation and memory deficit. This is, herpes encephalitis. And posterior, any posterior headache, occipital, suboccipital, and brief headaches, Arnold Chiari malformation or other posterior fossa lesions to be kept in mind. And progressive and pattern change. Progressive means increasing every day. So these are cerebral venous thrombosis. The diagnosis missed for about 7 to 8 months. And papilledema also missed. And pattern change means I do get an occasional headache once a month or twice a month, but now I'm getting every week or twice a week. So that also is a dangerous headache. And post-traumatic, even trivial trauma can precipitate subdural hematoma, maybe weeks or months later. Sometimes even the patient might have forgotten the history of trauma, usually in the elderly, and subdural hematoma can be a great CNS mimicker. It can present with headache, present like Parkinson's, stroke, and dementia. So any new symptom, any unusual symptom with headache, try to elicit a history of trauma. And with a CT scan, you can diagnose this. And post-traumatic again, yeah. Then second is past history of cancer. Breast cancer. This patient surgery was 3 years back. She presented with new onset headache, loss of appetite, weight loss. They never think that breast cancer is the cause for headache. So always go for a detailed past history, a complete history, so that you can suspect secondaries, metastasis, and investigate immediately. And prolonged aura. Whenever aura lasting more than 60 minutes, you go for imaging, stroke protocol. These are, migrainous infarct. So anything lasting more than 60 minutes is a case for imaging. And persistent aura, again prolonged aura. There are some very rare entities like CADASIL, cerebral autosomal dominant arteriopathy, subcortical infarct, and leukoencephalopathy, Sturge-Weber syndrome, trigeminal encephalotrigeminal angiomatosis, Handel syndrome, transient headache, neurological deficit, and lymphocytosis, cerebral amyloid angiopathy, and APSE and ASUR, two neuro-ophthalmological syndromes, acute idiopathic blind spot enlargement, and ASUR, acute sonal occult outer retinopathy, where you have to refer them to an ophthalmology, the first four ones to a neurologist. And petite aura, very brief aura, can be migraine aura, but whenever you get aura lasting seconds or maximum 2 minutes, think of epilepsy, a seizure, benign occipital epilepsy. And it can be secondary ominous, AV malformation or cavernous angioma. They are usually colored and they get uh, automatism. They can get, at that time of aura, they can get rapid blinking, gaze deviation, head deviation, flickering, and nystagmus, if you can examine them at that time. And PMR, another P, polymyalgia rheumatica, that is, diagnostic of giant cell arthritis, elderly patients above 50. You can see this dilated, tortuous, superficial temporal artery, and they can get, shoulder pain, neck pain, back pain, and hip pain. They get pain everywhere. And where no imaging, you go for ESR CRP to diagnose giant cell arthritis. And then comes three pressures. First is blood pressure, the most important. You have to check BP of every headache patient. And according to ICSD-3, experts, for BP to cause headache, it must be more than 180, 120. And many of you will not agree to this. Even moderate BP can cause headache in a headache prone patient, a patient with migraine diathesis. So this is controversial that you have to get more than 180, 120 to get headache. Second is, intraocular pressure, eye pressure. You can get subacute angle closure glaucoma or intermittent angle closure glaucoma, which can mimic migraine. Usually in the elderly, above 50 patients, they get a new kind of headache when they are in the dark, in dim illumination, when moon is out there in the sky. So it is known as moon migraine. They get headache with vomiting. And nearly 30%, 40%, it subsides spontaneously. They switch on light, they search for pain balm or pain tablet, take it and sleep off. And sleep induced meiosis will abort these episodes. So when they wake up the next day, there will not be anything. So when do you suspect it? When you have these symptoms, blurring of vision at that time, conjunctival congestion at that time, halos, or orbital pain. And headache will be always a new kind of headache. Even if they are getting headache in the past, this will be a new kind of headache. You can also do a flashlight test. You shine the torch from the temporal area onto the eye and see the shadow on the other side. You see this iris shadow. If it is 50% or more, then that shows there is iris bulge, and one must rule out angle closure glaucoma. You have to get a gonioscopy done by an ophthalmologist. You can also look at the pupil. You see these, atrophic areas that shows past episodes of angle closure. Now look at the acute glaucoma triggers. No, very benign innocent triggers can precipitate acute glaucoma. Prone position, dim or dark light environment, prolonged near focusing, stressful situation, anesthetic agents, sneezing, and high hypermetropes. So these patients are prone to get acute angle closure. And periodic strabismus, they get squint only occasionally. Most of them are benign, but these patient with a posterior fossa tumor presented with, headache, posterior headache with on and off squint, not every day, not all the time. So whenever you get such a patient, remember posterior fossa lesion. and pheochromocytoma. Whenever you get brief headache episodes, very brief, less than 15 minutes or less than 60 minutes, very short duration headache with one of the minor P's, palpitation, blood pressure, perspiration, panic, or pallor. So if you get one of these symptoms along with short duration headache, you think of pheochromocytoma. And you know the origin is not in the head but in the GIT. So you have to go for abdominal scanning. And personality changes or psychosis, any acute psychosis, recent psychosis, anything, behavioral change, mental changes, aggressiveness, lethargy, weakness, all those symptoms, unusual symptoms, you think of a frontal lobe tumor. It could be temporal lobe also or limbic system. These two are frontal lobe tumors presented with lethargy and disorientation, apathy, with headache. And you look at the physical triggers of reversible cerebral vasoconstriction syndrome, which is a thunderclap headache syndrome, where you need MRA. MRI will not reveal this. You have to go for an MRA and occasionally repeat MRA. First MRA may not show anything. And see the triggers: sex, emotion, showering, Valsalva maneuver like cough, exercise, and bending. So many trivial, innocent triggers can precipitate very severe headache. And always spend 1 or 2 minutes extra to elicit these triggers. And look at this carotid dissection. Again, very trivial triggers: coughing, sneezing, childbirth, athletic activities, painting a ceiling, carrying heavy load, riding a roller coaster. All these have documented to precipitate carotid artery dissection. And recurrent, puking recurrent. This patient, with a cerebellar infarct presented with headache, posterior headache with continuous puking. So whenever you get a patient who is headache with continuous puking, always go for imaging, rule out a posterior lesion. And pregnancy and postpartum, puerperium, you can get headache, and these are the lesions documented: reversible cerebral vasoconstriction syndrome, carotid artery dissection, IAH, pseudotumor, cerebral venous thrombosis, PRES, posterior reversible encephalopathy syndrome, pituitary apoplexy, and lymphocytic hypophysitis. But commonest is always migraine. So whenever they complain of a new onset headache or a different kind of headache or any CNS symptom other than headache, you consider these differentials and go for imaging. This is, phakomatosis. Phakoma, that. They get, facial angioma. These are facial angiomas. Whenever you get facial angioma with headache, same side headache, or prolonged aura on the same side, you think of Sturge-Weber syndrome and go for imaging. A CT will show this calcification. This is the tram track sign. This is leptomeningeal carcinomatosis. And also they can get glaucoma. Unfortunately, these two patients lost 50% vision by the time these glaucomas were diagnosed. So whenever you get this hemangioma, even without headache, send them for an ophthalmic checkup, intraocular pressure to be measured. Now, pupil. Whenever you get a headache patient, always scan the pupil. Compare both the pupils, see the size, shape, reaction, and any peripupillary changes. And of course, always look at the vision. Basic vision you have to look. So you may be able to pick up, a glaucoma or carotid dissection with meiosis, ptosis, or something known as third nerve palsy. So always look at the pupil. Now, painful eye with autonomic symptoms. That is usually trigeminal autonomic cephalalgia, but you can also get secondary trigeminal autonomic cephalalgia, more of pituitary lesions. And the red flags for trigeminal autonomic cephalalgia, where you go for imaging, is old age onset, not responding to treatment, and symptoms and signs outside ICH3 criteria. So you master ICH3 criteria for trigeminal autonomic cephalalgia and myosistosis persisting. They get recurrent episodes, but after the episode also these two signs persisting. That is very important that you go for imaging. And these are two more P's. One is a prothrombotic state. You consider cerebral venous thrombosis. When I say prothrombotic state, cancer, polycythemia vera, pregnancy, oral contraceptive pills, and patients on hormonal replacement therapy. When they present with headache, you have to keep in mind cerebral venous thrombosis. And then pounding. It is not throbbing, it is hammering or crushing with a brick. I have two colloid cysts of the third ventricle with complaining of pounding headache, as if somebody is, hitting them with a hammer or somebody is crushing them with bricks. So always remember that. And they can also get postural headache. When they lie down, no headache. When they get up, they get headache because the tumor is obstructing the foramen of Monro. So now conclusion, ominous headaches are rare in daily practice, but they can surprise you on any day and they can be easily missed as they are uncommon. Be familiar with ICH3, beware of red flags, and memorize red flag mnemonics. Thank you.
Thank you so much, sir, for your presentation. While we wait for more questions to come in the chat box,
Okay.
can you we can start with a short to-do list or something that we should keep in mind.
Okay. One thing, always go for a meticulous history. That is the most important. And based on history, you plan, physical and neurological assessment. You don't have to go for a complete assessment in every case, but basic assessment one must do. And always triggers are important. To diagnose migraine also you need triggers. I have these very common migraine triggers in my region. You can diagnose migraine from those triggers like exposure to sunlight, traveling by bus, missing a meal, late night or sleep disturbances, and very strenuous physical exercises. And I also have a mnemonic for, trigeminal autonomic cephalalgia known as Obama in. I coined this mnemonic when Obama was in office. O means orbital or one-sided. These trigeminal autonomic cephalalgias are always one-sided and usually orbital or supraorbital. That is O. B is brief. They are very brief, not like migraine, 4 hours or more. And AM is autonomic manifestation, congestion, lacrimation, rhinorrhea, meiosis, ptosis. And the last A is agitated. They just cannot keep quiet. They just cannot lie down the way a migraine patient, lie down. So they will be agitated, restless, and pacing the floor. And in is Obama in. In is indomethacin. Two of these entities, paroxysmal hemicrania and hemicrania continua, are absolutely responding to indomethacin. So triggers very important. And whenever you get a problem headache, not fitting into migraine or trigeminal autonomic cephalalgia, look at the other triggers like the glaucoma triggers, carotid dissection triggers, RCVS triggers. So spend some time on triggers. That is very important. And always tell them that there is a small possibility. There are no signs present. Only symptom, only headache. There is a possibility you will be not getting any positive sign. So you can tell them there is a very small possibility it could be a problem inside the brain. So better to get a scan or better to get blood investigation if you are suspecting giant cell polycythemia vera, such you know such symptoms and such diseases. So where you don't have to go for imaging.
Yes, sir. So we have a few questions. I'll take them up one by one.
Okay.
Dr. Agrawal has asked how to differentiate between psychosomatic or hysterical headache from the other types of headache.
I think best thing is to rule out the common uh, primary headaches. Migraine, you have the diagnostic criteria. Tension, you have the criteria. And trigeminal autonomic cephalalgia, you have the criteria. And other primary headache criteria. So go into ICH-3, learn these diagnostic criteria, and then differentiate these hysterical or psychosomatic from the common headaches that you get. And hysterical patient, psychosomatic patients can get this migraine tension. So those symptoms of, hysteria or psychosomatic symptoms, you can suspect, these are secondary to psychosomatic or hysterical symptoms. And there is this group 12 in ICH-3, psychotic symptoms and other psychiatric symptoms. So you can also go through those criteria, somatization disorder and psychotic disorder, where they say you have to get the first episode before 30 years of age, and you get other symptoms like other than headache, other pain symptoms, abdominal pain, menstrual pain, back pain, and two pseudo neurological symptoms like hallucination, diplopia, imbalance. So I think better to learn those criteria and you can differentiate. What I have seen in my practice, migraine patients with psychosomatic and hysterical symptom, it's very difficult to treat. You know, you need a psychiatry treatment or other psychological treatment. Then only the migraine drugs and other primary headache drugs will be beneficial for these patients.
Yes, sir. Moving on to the next question, sir. Dr. Shah has asked, how can you elaborate on trochlear headache in benign group of headaches?
Yeah, trochlear headache is not in the primary group, it is in the secondary group, but it is basically a benign headache where you get orbital or supraorbital pain, and eye movement will be exaggerating headache. Or sometimes they get headache when eyes are moved up because of the trochlear action. And you get tenderness there, and sometimes you get diplopia. Okay, yeah. And you can give a local injection of lignocaine, and usually you get very good relief for a long time. So it is a benign headache, even though it is in the secondary group.
Yes. Sir, there's another question by Dr. Bandrar. Do floaters have any relation to brain lesion?
Eye floaters, when I say eye floaters, floaters anyway, usually from the vitreous. So you have to get an ophthalmopinion and like PVD, posterior vitreous detachment, you get floaters. Myopes, you can get floaters. When you get flashes, that is where you think of, visual pathway posteriorly or similar visual hallucination, scotoma, scintillation, flickering, zigzag, star like, strobe light, all these have been described. Dots, spots, if they are moving and if they are transient, then you think of, a visual pathway lesion. And if they get a migraine headache along with these, floaters or floating sensation, it could be aura also. But then that can last more than 5 minutes. If it is lasting more than 5 minutes and less than 60 minutes, you can, and they get a migraine headache, then you can correlate that with migraine headache. Otherwise, better get a complete ophthalmic checkup for floaters. But brain lesions can cause something similar, but usually we call it hallucination, not a floater. It is a hallucination. So if it is hallucination like appearance, then it could be a brain lesion. Otherwise it is a local problem. Yeah.
Um, Dr. Thomas has asked, does headache or what does headache on waking up signify in morning?
Pardon. Headache in.
On waking up in the morning?
Okay, yeah. Early morning headache.
Yes, sir.
Early morning headache, classically that can occur in raised CSF pressure. They lie down, CSF getting accumulated, just cannot drain down. So the pressure increases and they wake up with headache. So that is the most important early morning headache cause. But then you can get something like sleep apnea headache. They get up early morning with headache. So that is why snoring is important when they present with early morning headache. Second, nocturnal hypertension. Some people get BP hike only in the night, so they can get up with headache. And nocturnal hypoglycemia. Whenever they get hypoglycemia early morning, they can get headache. And also medication overuse. They take frequent medication every fourth hourly or sixth hourly. Once the medication effect is not there, they get headache and they wake up. And of course, you can get migraine, tension, etc. early morning. There is no, you know, rule that you will not get these well-known entities early morning. You can get. That is one slide I discussed. Nocturnal headaches.
Yes. The next question is by Dr. Anarwala. How to differentiate between cluster headache and trigeminal neuralgia?
Yeah, that is a very good question. I address trigeminal neuralgia first. That is, a very unusual headache. They will tell you. That is usually neuralgic pains are stabbing, shooting, lancinating, electric shock like sensation, and sometimes it can be very boring. So it is not the usual migraine headache that you get, and it is only fraction of a second, maximum 2 minutes, very brief. And there are very benign triggers like brushing, combing, like eating, whistling, all those very benign triggers precipitate it. A cluster headache, it is usually 15-20 minutes. It is not that very brief headache. And you get, they are agitated, restless, and they get autonomic symptoms. Trigeminal neuralgia, very unlikely you get autonomic symptoms, but mild autonomic symptoms have been reported. But cluster people get profuse autonomic symptoms. That is the main difference. And this one will be usually that stabbing, shooting, lancinating, shock like sensation, and very brief. Of course, you can get very brief in cluster group, trigeminal autonomic cephalalgia like Sankt and Suna. They are only seconds, like trigeminal neuralgia. Sometimes not very easy to differentiate between Sankt, Suna, and trigeminal neuralgia.
Yes, sir. Sir, Dr. Devra has asked how to distinguish a malingerer from a genuine headache patient, as there is no instrument available to measure or confirm a headache.
That is very difficult, very tough question. That is what I tell my patients. You are telling me headache, I just have to believe you. But one thing what I have seen, you go into the details, then you know whether it is malingering or not. A genuine patient will give you classical, migraine symptoms or cluster symptoms. A malingerer will not give you that typical migraine or cluster symptoms. Yeah. And if you go deep into the history, you may get some reasons why patient is, giving such a symptom. But you can, to avoid a duty, to get leave and all that, I have seen people malingering and yeah, coming to me with a headache. Where you have to believe them. There is no way you can prove that the patient has headache. Where I think history is the most important. You can suspect a malingerer from history. Yeah, a meticulous history. That is what I say. A meticulous history, a very detailed history. I usually spend something like 30 minutes for such patients. Yeah, to differentiate between a genuine headache from a malingering hysterical headache.
Yes. Dr. Jitendra Shah has another question. Mechanism of indomethacin in relieving certain headache, say paroxysmal hemicrania or trigeminal related headache.
In pH, usually they say the CSF pressure decreases. That is the main mechanism given, the pressure, CSF pressure, and maybe, some less blood flow also. So that those are the two mechanisms. Yeah, more of decreased CSF pressure, maybe less blood flow and less CSF formation. Yeah.
Dr. Dinesh has asked, headaches in an alcoholic patient, what can be the cause for it?
That is, not very easy to uh, find out the cause. You can get both cocktail headache and hangover headache. Cocktail headache is immediately after consuming alcohol. Hangover is 3 to 5 hours later. And it may be alcohol itself, or it may be metabolites, alcoholic metabolites, or some people say it may be dehydration. When they drink, the water consumption is less, so maybe dehydration. So these are the possible causes given. Yeah, but we do not know exactly what exactly is the cause.
Yes, sir. Um, we have a couple of more questions, sir. One to more.
Okay, no problem. Yeah.
Yes, sir. Um, Dr. Ahmed has asked, some patients complain of a hissing sound with an headache.
Yeah, they can, complain of hearing problems. They can get tinnitus. They can get, those unusual sensations in the ear. So I think that is part of a migraine spectrum. Those are not in the diagnostic criteria. Those are not in the ICH3 document. Those are, symptoms which we haven't studied well. So, but those symptoms are possible. You look at vestibular migraine, they can get tinnitus, they can get transient hearing loss, and they can get, ear block. So those symptoms are there. So you just cannot, explain that uh, very well why they are getting it. Maybe if blood flow changes. Basically it is, first a neuronal activation, then there is, blood flow changes, excess blood, less blood. So that may be the main reason why they get such sounds. Yeah.
Yes. Another question here is the role of CT and MRI in diagnosis of a headache patient.
CT, MRI, depending on the red flags. If there is a red flag, and if it is not like giant cell arteritis or, other blood related headache like anemia, polycythemia, or something like, urinary, renal problem, hypercalcemia. So there are such systemic complaints which can cause headache. So in that case, you have to go for blood investigation. Otherwise, you look at these red flags. So you can remember snoop and see the red flag is there or not, and go for CT scan if it is available nearby, or if it is, uh, CT negative, you go for MRI. I think first you go for a CT scan. But if you get, conditions like CVT or optic neuritis, Such conditions, Tolosa-Hunt syndrome, if you suspect clinically, go for MRI. Or third nerve, sixth nerve, and all, you better go for MRI. Otherwise, I think CT will be the first investigation, provided there is a red flag. You have to justify why you are sending for CT scan. So you can say that because of this red flag, better to get a CT scan
Yes.
first. For us, in my place, there are three CT scans, but no MRI. MRI people have to go to, Alleppey City or Kochi, which is, little far away, and there is a time gap. You may not get MRI on the same day. You may have to wait for a day, 2 or 3 days. So usually I get a CT scan, but I tell them you may have to go for an MRI scan later if CT doesn't show anything. Yeah.
Sir, just a follow-up question on this. Do we do a non-contrast or a contrast enhanced PC?
That is what. If you get a thunderclap, go for non-contrast. That is where you have to go for a non-contrast. And of course, people give contrast and do CT angio if there is a suspicious, bleed inside. Yeah. So and trauma, you can go for a non-contrast. Subdural hematoma, you can go for a non-contrast. But conditions like Chiari malformation and all, you have to go for MRI. Contrast MRI, sometimes contrast MRI. Otherwise, I think plain CT first. What I write, plain CT, I give the history, possible, diagnosis, and contrast if necessary. That is what I request the radiologist. The radiologist think that contrast is necessary, he can take the decision. In headache cases, yeah, not every case I advise contrast.
Yes, sir. We'll just take one more question, sir.
Okay.
Yes, sir. After a vasovagal episode, what is the cause of a headache in a patient?
Vasovagal syncope and headache.
Yeah.
I think vasovagal syncope. Why vasovagal syncope? I think that is the most important. Whether it is stress, standing for a long time, whether there is no sufficient fluid, and whether the patient is a migrainer. They can get syncopal episode. Those are the extra cranial migraine symptoms where you get a syncope or syncopal episode. So you have to go into the history and see what exactly is the cause for vasovagal syncope.
Yes.
Yeah.
If I think there's a time for one more question, can I please?
Okay.
Uh, current like unilateral headache with temporomandibular joint arthritis is a patient's symptoms.
Current like unilateral headache with the temporomandibular joint arthritis. I think that we consider that as TMJ dysfunction, temporomandibular joint dysfunction. So you can get all these sensation, current like and like neuropathic like pain they get, and usually you can try, you know, NSAID, non-steroidal anti-inflammatory, and I advise them not to chew on that side for about 2 to 3 weeks, NSAID, and tricycling. Usually, they can be stressed, they will have sleep disturbances. So I try that, then I refer them to an MDS, a dentist with, experience in these temporomandibular joint problems. Yeah. So you can try, but 80% you can treat on your own. You don't have to refer them to a dentist or a PG dentistry, temporomandibular joint expert. Yeah.
Okay. So I think that brings us to the end of the Q&A session as well. Thank you so
Okay.
much, sir.
Okay. Thank you.
Yes, thank you so
Thanks.
much to our audience also for sending us questions and joining today's session.
Okay. Thank you.